Today, our state API chairman, Dr. Sethuraman sir. So he came as a guest of honor. I welcome you, sir, to come to the dais. Good evening, sir. Next, I welcome our chief guest, our speaker, Professor Dr. Jayakar Thomas, sir, and I welcome to the dais, sir. Welcome, sir. So next, I welcome our API Vellore branch, so chairperson, Professor Dr. Seshadri, sir, to come to the dais. Thank you, sir. So, we can move on to our API meeting. So, we'll start with the physician prayer. I request everyone to stand for a few minutes. So, dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the privilege that is mine. Take from my heart all guilt and worthiness, that with the simple faith of a child I rely on thee. So, thank you. So, now I welcome Professor Dr. Seshadri, sir, to deliver the welcome address.
Thank you very much. Dear friends, I consider it a proud privilege to welcome all of you to the 46th continuing medical education of the Vellore chapter APA. This meeting is special because we have our chairperson of Tamil Nadu APA, Dr. Sethuraman, who has come all the way from Trichy to grace the occasion and talk to us. And we also have Professor Jayakar Thomas, a very distinguished dermatologist who is currently working as professor in Chettinad Medical College. The Vellore chapter of APA is a relatively young chapter, and we'd be grateful to Dr. Sethuraman for ideas to increase the membership and the spirit of APA in this particular chapter, because with his experience, I'm sure he'll be able to tell us how to take things forward. He has already been talking to us about some of the things that we can do to make this a very vibrant chapter. Welcome you all once again, and have a very pleasant evening.
Thank you, sir. Now I invite our API Vellore branch secretary, Dr. Manikandan, sir, to deliver the secretary report.
Good evening to one and all. I extend a warm welcome to all the friends and to a distinguished guest of honor, Dr. Sethuraman sir, chairman of Central APA, Tamil Nadu APA, and also to a distinguished speaker, Professor Dr. Jayakar Thomas sir, for delivering the CME, and also all my friends who have joined this evening. Actually, the Vellore APA has been conducting CME regularly, both online and offline, depending upon the situation, to update knowledge to the physicians about the recent concepts and the latest guidelines. As a part of it, now we have Professor Jayakar Thomas sir to speak about skin and diabetes link. Actually, to be frank, to get the sir's appointment, we have been trying for the past 3 to 4 months, I think. Sir, no, at last we got this day, actually. So thank you, sir. Thank you for coming to us. And this is very special for us because our state chairperson has joined us. Thank you, sir.
Thank you, sir. Now I welcome our past chairman, so Dr. Go Bharani ma'am, to introduce our guest of honor, Dr. Sethuraman sir, API chapter chairman, and also to give us short words about the history of API Vellore branch. Okay, ma'am.
Good evening, respected chairperson Dr. M.S. Seshatri sir, and the organizing secretary Dr. Manikandan and treasurer Dr. Anita, and our chief guest Professor Sethuraman, and our guest lecturer Dr. Jayakar Thomas, and all our friends. I'm very thankful for giving me this pleasant job of introducing Professor Sethuraman from Trichy. He is our chairperson, API Tamil Nadu State, and he is going to conduct the state API in Trichy in November also. He is from Tanjore Medical College, and because of his presence, we also have Dr. Tyagarajan with us, who is his classmate, and he did his MD General Medicine at Stanley Medical College, and he has held various prestigious posts like State IMA Vice President, State IMA Joint Secretary post, Trichy IMA President, and Trichy IMA Secretary, Club Trichy, Trichy API Chairman, and now API Secretary Tamil Nadu. We welcome you, sir. As Professor Seshatri told, we'll be enlightened to how to improve our API. And I'll just tell you a short story of how Vellore API chapter was started. It's a story of pride of physicians, actually. 5 years back, Dr. S. Kumar expressed his concern that many doctors, or even not even doctors, acupuncture and so many people are putting MD degree behind them and practicing. Shouldn't we do something about it? Then I told, yes sir, but what is the pride of physicians? It's our quest to learn and share knowledge. Let us join together and start doing that. And there is a state physician chapter, so we'll join them. But immediately Dr. Sukumar contacted the state people, and he has the clarity and capacity to execute, and within few months with Dr. E. Prabhu and Dr. Shanmugam came and inaugurated API. Since then, we are conducting regular CMEs. CMC people also joined us, and CMC postgraduates and Vellore Medical College postgraduates used to present cases. Our usual agenda used to be one chief guest lecture and a short slot for the former people who sponsor, a way of drug history or a case trial or something like that, and PG will present one or two cases, interesting cases. Then Dr. Satish expressed that we should do something for the general physicians, also general practitioners, so we conducted 2 or 3 meetings to enlighten them. Most of the super specialists of Vellore district joined us and gave some lectures, and Dr. Raja, rheumatologist, and we're all now regular resource person for API state chapter also. And we were called as a resource person for state chapters, and Dr. Sukumar and Dr. Satish are already executive members of state API. And Vellore API now, though it's a very short 5 years period, it's known for its integrity and harmony. So I'm very thankful to be a part of this, and because of API we are able to get associated with Professor Seshatri and so many eminent people. So I'm very happy, sir, for coming here and be with us this day. And I also welcome Dr. Jayakar Thomas. He is also was very well known and a very favorite teacher for all the dermatologists. So thank you very much, sir. Welcome you.
So now I invite Dr. Bharani ma'am to honor our state API chairman, Dr. Sethuraman sir, with the fruit bouquet and gift of honor. Now Now I invite our past chairman, Dr. Sugumar sir, to introduce our guest speaker, Professor Dr. Jayakar Thomas sir. I welcome you, sir.
Thank you for the opportunity given to me, the API team of Vellore. This is a pleasant evening today to have a good get-together. It is my nice duty to introduce my friend, Dr. Jayakar Thomas. The introduction depends on two parts. One part is about friendship. Second part is about his academic events. So, I like to inform you that Jayakar, myself, Dr. Kodandabani from Gudiyatham Dermatologist, we were students in Government Stanley Medical College in 1970. 50 years over. So, the first 10 years were very pleasant during the college days. We had a Stanleyan spirit and we had enjoyed the Stanley life. After that, we separated in different places, different countries, different categories, different specialities. We separated for some 5-10 years. Then again we started meeting together in occasions like marriages, functions, etc., etc. We thought, why can't we reunite again? So from 2020 onwards, we are reuniting every year. Every December of the every year, we used to reunite in different parts of the state. The doctors' friends who were in Salem, Coimbatore and all, they take in charge and conduct the get-together. We enjoyed the days. As soon as we meet each other, we feel the Stanleyan spirit and we got up in life. So that's a nice occasion. Thomas was very good in organizing the friends and doing things. In our batch, we were 100 people at that time admission. Now we are around 60, I believe, Thomas, our batch people. So we lost about nearly 40 people during the 3 decades. That was the history of our friendship. So next about academics. Now, Professor Jayakar Thomas presently is the Professor HOD of the Chettinad Hospital and Research Institute. Really, the Chettinad Hospital is to be very lucky to have Thomas as the HOD of the dermatology. His past affiliation is Professor HOD of the Tanjavur Medical College, Tanjavur, Sri Balaji Medical College, Chennai, and years of experience, more than 40 years of postgraduate teaching and training. Officers held National President 1998, IADVL, National President, Indian Society of Teledermatology. See, the teledermatology is a nice thing. He has been doing the teledermatology practice for more than 15 years. He has patients around the world. Every day, at any time, he contacts people. Many different country people are in contact with him for treatments. The teledermatology is very favorite for him. Many people are in and around the world are benefited because of his teledermatology practice. He is International President 2012 to 14, International Society of Teledermatology. His major achievements, K.C. Kandari Foundation Award, Lifetime Achievement Award for Teaching and Practice. He has been given the Best Educationist Award. Best Educationist Award for his teaching and guidance in dermatology to students. He is a teacher of teachers. He did a lot of research in dermatology. Mother Teresa International Award, International League of Dermatologic Societies Award, Award of Appreciation, IMA Best Doctor Award, IABDL Teacher for Excellence Award, published over 200 original scientific papers, published books on the pediatric dermatology, psoriasis, genital dermososis, acne, alopecias, contributed chapters in text of dermatology, pediatrics, adolescents and allergy. I remember correct, in 1992, we invited him for Gudiyatham Indian Medical Association. Professor Seshadri, I don't even remember, and Dr. Seshadri and Jayakar was the speaker on that day in 1992, almost 20 years now. Both of you attended the meeting in Gudiyatham IMA. Now I am seeing the same batch of panelists today on the batch. So I am happy to reunite again. So he is a good friend, good human being, eminent dermatologist. We are here to listen to him. Having heard this through Dr. Sethuraman, API of Tamil Nadu, many of the doctors are started asking about this speech. So we arranged for a Zoom meeting, as well as we are going to publish it in the YouTube also. So such a beautiful talk we are going to expect now. So it is a nice event today evening. Also the sponsors are very helpful in doing this meeting. So I welcome all the three chief guests for this meeting. Over to.
So, and I request Dr. Sugumar sir to honor our renowned speaker, Professor Dr. Jayakar Thomas sir, with a small mementos. Now I welcome Dr. Sethuraman sir to share a few words about this meeting.
Good evening to all of you. I am extremely happy to be a part of this Vellore APA meet today's evening, and also able to listen to a great renowned dermatologist of the field, Professor Jayakar, and happy to meet my classmate Dr. Tyagarajan. And overall, it is a very pleasant evening today. My respects to MS Sheshatri sir, Chairperson API Vellore, Dr. Manikandan, Secretary, Dr. Anita, Finance Secretary, and the past Chairman, Dr. S. Sugumar, who is instrumental in bringing me to this evening, and Dr. Narasingan and Dr. Bharati, all the past chairmen. And also, I am very happy to meet the genius in dermatology, Professor Jayakar Thomas sir. As you know, the skin is the mirror of diabetes, and we have heard of diabetic nephropathy, retinopathy, peripheral neuropathy. All pathies are there. Today we are going to have a lecture about diabetic dermatopathy, and sir is going to give. As soon as I came to know that Dr. Jayakar sir is giving a lecture, I forwarded the invitation to my classmates batch. One of my classmates, Dr. Jayantini, who is a psychiatrist in Chennai, she said, I am a fan of Dr. Jayakar Thomas, why can't you make it a link? Then I requested Dr. Sugumar to have it on the link, to keep it in the Zoom link and also in YouTube. He happily accepted, and he did all arrangements in 1 or 2 days. Thankful to Dr. Sugumar and the branch of API. And many people are watching. I have forwarded to most of the Tamil Nadu API WhatsApp, as well as the other groups. And SARS close person, Dr. Ashraf, he is also watching, he is on the line. So all the physicians and dermatologists are watching, though the attendance is fairly thin, but it is not so, because his speech is heard all over Tamil Nadu today in API EC meeting. And also Vellore is geographically, he's played a vital role in the medical field from so many years, and I'm happy to be there. And regarding the API Tamil Nadu, I want to have 1 or 2 minutes only, take your time. API Tamil Nadu, we are conducting the annual conference of the Tapicon in Trichy coming November, and it will be a grand occasion, and it will be a 2 days function, and the first day, the third day, 3 days function. First day will be for the postgraduates to present, to have a gold medal examination, to present poster presentation and other thing. Second and third day will be of lectures. On this occasion, I invite all the members of API and also the postgraduate students to participate in the Tapicon, which is going to be held in November. The new hotel is coming up, the Courtyard Marriott. We have booked that hotel to have a good ambience, and we expect a large number of people to attend. And Professor Damas also accepted to be a part of the faculty, Jayakar Thomas. And as the aim of API, Tamil Nadu, not only an academic activities we have planned, and also we have to do a social activity. Any organization, if they don't reach the people, it will not be familiar. Even any philanthropist or corporates, they are all having a side-by-side philanthropic activities towards the people. TVS, Tata, all those people, not only industrialists, they are all doing some social service, Birla, Mandir. So whatever it may be, the corporates, they are reaching the people because of their social activities. So we have also to have all the some social activities to get into the public. For that, in Trichy, what we have done is we have printed about thousands of good notebooks, binded notebooks, to be given to the medical colleges to write the discharge summary of the patients who are getting discharged from the Department of Medicine. That book, they will keep it forever. I saw the postgraduates are writing in some paper, and they are coming with the Paka records. All investigation, they miss it. So we have planned for that, and with the Dean and the Professor of Medicine, we have handed over, and we said we will refill it once it is exhausted. So it is having a good catch up in the Department of Medicine at Vellore, I mean in Trichirappalli, KAP Medical College. I have asked all the branches to prepare such a notebook, discharge notebook, that is complaints, treatment, specialty opinion, treatment given, what is the advice, what is the follow-up. That book is a good notebook, school notebook, Mari. It's like a diary. The patients can keep it. Now, even though not for all fever or something, all major cases, postgraduates can write it and give it to the patient. They will keep it forever. That is one of the idea. It was hatched up in API. And another one which is pricking for a long time is we have to look after our own colleagues. It's more important. That is, most practitioners in the rural area, they are not having approach to the specialist. Somehow or other, they don't come forward for any medical checkup, or they no acquaintance with the seniors in the city hospitals or the practitioners. So it is our duty to get the medical practitioners in the rural areas to have a medical checkup for at least once a year. That is my idea for them, because it has happened once. One of our general practitioner, when he was coming on the scooter, he swooned and he passed away. Later on, pursuing his records, he was having a cardiomyopathy. So in that case, if he has consulted somebody and if he has cautioned properly, he would not have strained too much for the profession. This is the general practitioners of our own colleagues should be treated, do an echocardiogram, lipid profile, HbA1c, for them to arrange one medical checkup program for them in all the in each branch has to take up. And also another thing is membership drive. Any organization, if the more members are there, it will have a strength. So membership drive, we must include all postgraduates, all other allied specialties like chest physicians or the psychiatrists or medicine allied people also can become the API member as associate member. So they can have every rights to participate in the API activity except the voting rights. And the postgraduate also can join the API. Once they are also postgraduate, they can pay only 50% of the subscription as a life member. Once they complete the degree and got the degree, they can become a full-fledged member by paying the remaining amount. why we have to encourage the postgraduates is they will get acquaintance with senior people like our Professor Jayakar sir and other people. So they will have a enthusiasm, motivation to become a very big academicians. That is why we have got motivated. In 1987, I happened to meet A.B. Mehta from Bombay and Balajani in an API meet at Madurai. The way in which they presented the ECG and other thing in 87, we have become his fans and we have been attending all API meet. Like that, all postgraduates in Thiruvalluvar சொல்கிற மாதிரி பெரியாரை துணைக்கோடல்ங்கிற மாதிரி யார் கல்வியில் பெரியவங்க, யார் அனுபவத்தில் பெரியவங்க, இவங்களுடைய துணை இருந்தால் நாம் அவங்களுடைய இது நமக்கு கொஞ்சம் அவங்களுடைய இதெல்லாம் நமக்கு வரும், நம்மளும் பெரிய ஆள் ஆகணும், அகடமிக்காக ஆகணுங்கிற ஒரு மோட்டிவேஷன் வரும். அதுக்காகவாது எல்லாம் மெம்பர் ஆகணும். They will have acquaintance with all the senior people. And also this develops a friendship. Being a members in the any forum, it develops a lot of friendship and acquaintance with the senior people. For this only we have to motivate the youngsters to become the API members. These are all the few points I wanted to enlighten in this forum. And before we have been waiting for the guest lecture, which is more important. And I am very thankful for the Vellore API, especially Dr. Sukumar, for giving this opportunity to participate in this function. And thank you once again. Thank you very much.
So thank you so much, sir. And it was an eye-opener and about the social activities about the API meeting and to involve the postgraduates in the API activities. Thank you so much, sir. So it's high time to resume our most awaited CME, and it's been a great fortune to invite our renowned speaker, Professor Dr. Jayakar Thomas, sir, to deliver the guest lecture on diabetes and then dermatological manifestation. So I welcome you, sir.
Wish you all a very pleasant evening. At the very outset, I heard Dr. Anita recite the physician's breath. It was really impressive. I was looking at it, trying to capture as much of it as possible. Dear Lord, thy great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray. Give skill to my hands. Clear vision to my mind. And sympathy to my heart. And strength to bear at least part of the burden of my fellow men. That was all I could. Take away from me all guile and worldliness, that with the simple faith of a child I kneel before thee. That was very impressive. I tried to memorize a bit. Age is against it. But I think I did a fairly good job in spite of that. Okay, now coming back to a little bit of thing. I do not know how many of you youngsters knew that we dermatologists were part of the API. We did not have an Indian Association of Dermatology at all. It was in the year 1973 that a group of dermatologists joined and separated from the API and formed the Indian Association of Dermatologists, Venereologists and Pathologists. Now, that apart, I owe a big thanks to my good friend Dr. Sukumar. In December last year, he had invited me. He said, "Ready to come?" I said, "Most willingly." Unfortunately, Dr. Manigandan, there were a few things which I was committed with, and I could make it only in April. Otherwise, I would have loved to come earlier. So that's the way it goes. I thank very much the state chairman, Dr. Sethuraman, for inviting me to Trichy. Of course, the district chairman, Dr. Seshadri, for all the goodness and kindness. My former student, Varun, and all of you, Dr. Anita particularly, who seem to be playing a major role along with Dr. Manigandan. So without much of delay, I will start off with my presentation. I always put this slide because most of the pictures which I show might have the faces of the patient, and I take the pictures only with a written consent from them. And I would strongly appeal to you and recommend that you do not take any pictures of the patients. Any textual matter, you can always take picture and you can reproduce it after you get my written permission. Now, all of us know that diabetes is a very, very common condition. We have 1, 2, 3, 4, so many of us here. I'm sure 50% of us are having diabetes. And where skin manifestations are concerned, it's very, very common. It's very, very common. And if you were to look at the skin manifestation in diabetes, if you look at the skin manifestations by themselves, they equate to about 100% of incidence in diabetes. Now, I'm going to look at it from two angles. One from the metabolic angle, and two from the genetic angle. And what I'm not going to mention specifically is the epigenetics. Nowadays, for every disease, the epigenetics becomes very, very important. Now, looking at it from the metabolic angle, we'll find that, again, as I mentioned earlier, the prevalence approach is 100%. If you look at the microcirculation that results from diabetes and the effect that this microcirculation has on the collagen of the skin. Particularly, we are all aware, just what Dr. Sethuraman mentioned about HbA1c. We all know about the non-enzymatic glycosylation of hemoglobin. Now, hemoglobin is a protein, and there are several other proteins which can get similarly non-enzymatically glycosylated. The collagen, the elastic tissue, so many proteins within the skin that can get glycosylated, but this is non-enzymatic glycosylation. Therefore, what happens is the resultant effect is resistance to enzymatic degradation because they are non-enzymatic. Initially, is resistance to enzymatic degradation, mechanical thickness, the collagen, the elastic tissue, everything becomes thick. Insolubility and unwanted deposition of so much of proteins, particularly collagen, color changes, block to other much needed proteins. When the unwanted proteins coming, the much needed proteins get blocked and conceivable complications of the disease. I want to make one point very clear. I'm not going to talk much about the derm manifestations of diabetes. As my title says, what is the link? What is the link between the skin and diabetes? I partly put it forward with the metabolic changes that could take place. But that's not all. There are genetic changes that take place. And there seems to be genetic proneness when we talk about the skin in diabetes. And there are several examples. For instance, the Wolfram's or the Dietmar syndrome. Again, I want to reiterate the fact. I'm not going to talk much about skin manifestation diabetes. Most of you know about it. You have read it as undergraduates. But you'll find that this Wolfram gene is the short arm of chromosome 4. Why I'm pointing this out is, if you look at certain other genetic consideration and exemplary syndromes, the maturity onset diabetes of youth, again, the Modi gene is on the short arm of chromosome 4. What I'm trying to stress here is the importance of genetic considerations. They're all on the short arm of 4. You look at another condition, hemochromatosis with diabetes, a good manifestation, again in the short arm of chromosome 4. You look at other conditions where there is iron overload, there are other form of protein overload. Again, in porphyria cutanea, for instance, porphyria cutanea tata, you'll find that it is on the short arm of chromosome 4. What does this tell us, my dear friends? That the genetic commonness of so many diseases do exist. But I told you about the word epigenetic. Now, epigenetic means the genes do not change in their shape or form, but the genes are made to reflect their phenotype in a different way. Whether it is a medical problem, whether it's myocardial infarction, or even myocardial ischemia, the epigenetic factors will have to be looked into whenever we talk about a disease entity. Now, if I were to combine what I said earlier, the biochemical considerations in terms of the metabolic changes and the genetic considerations, good lot of diseases will come under that, and a good example is autoimmune polyganglioma disease. This is an example of porphyria cutanea tara where there is sun sensitivity, an example of how facial telangiectasia could take place. Fine. Of myxedema or pretibial myxedema more correctly. Alopecia areata, all these are known to be linked with diabetes, and in a short while I'll be telling you. But if I were to make a long story short, this is the best way to look at it, where diabetes mellitus is involved in infections, vasculopathy, neuropathy, metabolic changes, iatrogenic, a large group of miscellaneous conditions, and of course, syndromic manifestations of diabetes mellitus, which may not be important in this audience, but still, to complete the formalities, I will certainly mention them also. Now, with regard to cutaneous infections, today infections are not a very big problem. We are able to treat them very easily. We have a good number of antibiotics. However, there are several infections which characteristically occur in patients with diabetes mellitus, and some threaten life and limb. That's most important. When there is threat to the limb, that is what is compromising the patient. When there is threat to life, that is the end of it. So we must try to stop it at an early stage if possible. Now, all cutaneous infections are related to the immunoregulatory mechanism derangement, whether it is chemotaxis, phagocytosis, or bactericidal ability of the PMNL, which I shall show you slowly and tell you what this is about. This is what we call as the respiratory burst. Now, whenever we talk about the respiratory burst, we know it's a polymorphonucleoleucocyte. The chemotaxis is affected, the phagocytosis is affected, and eventually the destruction, that is the myeloperoxidase system, is affected. I want to impress this. I just don't want to walk away saying, oh, there are streptococcal infections, bacterial infections, and fungal infections. But how? The WBCs are totally paralyzed. The chemotaxis is stopped. Even if the chemotaxis occur, the engulfing, the phagocytosis is stopped. Even if phagocytosis occurs, the destruction of the bactericidal activity of the WBCs, which is dependent on the myeloperoxidase, does not occur in patients with diabetes. Good lot of infections are known to occur, particularly your staph infection where the hair follicles get involved. This is something a little interesting. For instance, the hair follicles could get involved in different ways. This is just a diagrammatic representation of the hair follicle, where it's only the mouth or the ostium of the hair follicle get involved, which we tend to see as a bead of pus. You find beads of pus also there. Or this is what happens in superficial folliculitis. Or it could be that the hair follicle lower down could get involved. Somewhere here it get involved, where you will see a nodule of pus when you look at it clinically. Or it could be the adjacent hair follicles getting involved, which we call as a carbuncle. This is how it will appear. Now this is very, very common, and rather the commonest, we can say, is superficial folliculitis, which is present in a lot of diabetes, and we tend to call them psychosis barbae. Now this psychosis, my dear friends, is spelled as S-Y-C-O-S-I-S. There is no P. There is no P in the psychosis. It is S-Y-C-O-S-I-S. It's only the P of the psychiatrist that is silent. So let's not bring the psychiatrist into this. My good friend Jayantini, they have already mentioned about her. So we won't bring the psychiatrist. Different example of superficial bacterial folliculitis could occur. Or it could be a furuncle, like this is where you see what I told you, a nodule of pus. Or it could be a carbuncle, where you see a bag of pus. A bag of pus is involved. When you palpate it, it will be like a bag of pus. So different examples are there. This you cannot put under folliculitis or any other form of folliculitis because this part of the hand does not have hair. There are no hair follicles at all. So you can't call it. It's just a pulp infection, secondary. I just brought it on to embrace the fact that this type of thing should not be called folliculitis. Now, a special form of folliculitis, which is known as hidradenitis suppurativa, killer disease. I tell you, so annoying, and it can be a killer disease. Killer in not that the disease directly causes death, but then it's one disease which can really cause a lot of psychological problem for the patient, leading on to suicidal attempts. This is what we call hidradenitis suppurativa. You can have it in the axilla, you can have it in the gluteal areas. It can be really, really troublesome and sometimes associated with the pilonidal sinus. The pilonidal sinus can be breaking open on and off and giving trouble, and a major manifestation of diabetes. Other bacterial infections, streptococcal infection, get the necrotizing fasciitis, which is life-threatening. Please, just don't take it like a streptococcal infection of the throat. Look at this, look at this. It'll look like cellulitis. It'll look like cellulitis, but we have to be careful. You have to be careful and make sure. Look at the blisters. This is limb-threatening, certainly limb-threatening if we do not attend to it early. And it's so easy to treat. So easy to treat. I'm not going to the modalities of treatment. If you don't treat it, this is what the patient is left with. Multiple ulcers, multiple ulcers. And when the patient comes in a situation like this, we do not know the cause for the ulcer. If it's on the medial side, we tend to call it a venous ulcer. If it's on the lateral side, we tend to call it an arterial ulcer, because both will be painful. Both will be painful, and we might go into a situation where the surgeon has to be called and part of the limb has to be taken away. More examples, things like this, which is not, it's not at all a stasis, not at all a varicose stasis ulcer, but an ulcer which has resulted from necrotizing fasciitis. Now there is another bacterial infection known as erythrasma caused by a special form of Corynebacterium, which is known as Corynebacterium minutissimum. Corynebacterium minutissimum. It appears as brown scaly patches with irregular borders. Why I'm telling about this? Look at this, what it looks like. Irregular border, brown scaly patches. Now, for some of the juniors who are seeing it for the first time, might think that it is a form of pityriasis versicolor. Same thing what used to be called as TV or tinea versicolor. We don't use the term tinea versicolor nowadays, we use the word pityriasis versicolor. Now it has to be differentiated. Look at this. Look at this young man and look at this young man. Both of them have got the brown scaly patches. But here you will find that the vault of the axilla is involved. The vault right inside is involved. Whereas here you will find that the vault of the axilla is completely clear. Why I brought this is to impress upon you that in erythrasma, which is a bacterial infection, the vault would get involved. Whereas in pityriasis versicolor, which is a fungal infection, the vault is spared. Therefore, your treatment completely changes. There's no point in giving cartloads of antifungal ointments or creams for this and cartloads of antibiotics for this. So that's it about thinking in terms of Corynebacterium minutissimum infection and Pityrosporum ovale infection. More examples. The Candida is yet another fungal which is known to occur in different forms: genital, anglostomatitis, hands and feet. The hands and feet itself, you can get paronychia, intertrigo, nail plate infections. I will go through this very, very fast. As I told you, I am not interested in just showing the manifestations or derm manifestations of diabetes. I am interested in impressing on you something deeper than that, something deeper than that. This balanoposthitis, any of you can diagnose and immediately send the patient for his blood sugar estimation, and where you'll be able to see recurrent anglostomatitis. Again, patient will manifest as paronychia. Paronychia, the two forms, one is acute paronychia, the other is chronic paronychia. Now, acute pyronychia has to definitely be treated by the surgeon. The dermatologist or the physicians have no business to touch it. Whereas a chronic pyronychia can be treated by the physician himself. Intertrigo, where the word intertrigo means inflammation of the skin between two opposing skin surfaces. Wherever, wherever there are two opposing skin surfaces and it gets inflamed, this inflammatory change is known as intertrigo. That's what the books say. I have added just one more point in that. It is inflammation of the skin due to friction between two opposing skin surfaces in the same individual. That's very important. When you get friction of the skin between two different individuals, that is not called intertrigo. Huh? It should be in the same individual for you to call it intertrigo. Examples, several examples of intertrigo. I'm going through this fast because I don't want any of you to be taking any pictures. These fungal infections are so very common, not only in diabetics, even in non-diabetics. I'm sure in your practice in a day you'll see at least 2 or 3. If you're in a busy practice, in a practice like mine, I see at least 10 patients of dermatophytosis or fungal infections a day because it's taken up by the general practitioner in a big way and steroid creams are given. So you have to be careful, diagnose them early, rule out diabetes, and it's the ring that gives off the diagnosis. Mine will be full of pictures. I'll show you the previous one. They told you sometimes wrongly treated with topical steroids, and this is what happens. Now, if this happens in this part of the skin, at least the patient can cover it up. But sometimes it happens on the face itself, what we call as topical steroid damaged face. So we have to be careful. Now, this pityriasis versicolor, what I showed you earlier, pityriasis versicolor. Now, why is dermatophyte infection or fungal infections important to us in terms of connecting it or linking it with diabetes? These are things which are not given in the books. The importance is the oxygen demand of the subsequent inflammation may far exceed the ability of the diabetic microcirculation, which is already compromised. So the moment you see a diabetic coming with tinea infection or fungal infection, treat it immediately. Don't wait. Don't wait for anything. Because the oxygen demand for that particular area of the skin will be very, very high. And looking at that, already the microcirculation in a diabetic is compromised. Therefore, treatment is needed essentially as early as possible. Now, this is one thing which has been holding, or rather been calling roost for a very recent time. Mucormycosis, which we talk about. This is way back about 30 years ago when I saw this patient. The first time I saw this patient, I made a diagnosis of herpes zoster. On the first day, I made a diagnosis of herpes zoster, ophthalmicus, sent the patient to the ophthalmologist for assessment, but fortunately even my friend who was there, an ophthalmologist, he said, Jayakar, no, this is something else. I don't know what it is. Then we tried to get the opinion of the EAT specialist also, and that time Professor Kameshwaran was there in Madras Medical College, and he said, no man, this is a fungus mucormycosis, and you have to be careful. Well, let's see the difference. This is herpes zoster ophthalmicus, and this is mucormycosis. So different forms of herpes zoster, again, is a manifestation of diabetes. But the link is sudden appearance of herpes zoster in an immunocompetent individual. Now, if you get it in an immunocompromised individual, we can all understand. But when you get it in an immunocompetent individual, one has to be careful and rule out diabetes immediately, wherever it might be, however small it might be. So that is the link which I would also like to impress upon you. Now, what about this diabetic thick skin? I already told you the biochemical inflammatory changes that take place and where the collagen in the skin tissue can really get very, very thick. Different forms of thickening are seen. This is a wonderful thing. You go tomorrow, sit in your clinic and look at these knuckle pebbles right here. You see the small pebbly thing. When you search for it, and if you find it, please rule out diabetes. This is something which is not given in the book. Knuckle petals. My colleague and I have published this. Knuckle. I will show you some more publications later at the end of the show. See this type of knuckle pebbling that could occur in patients with diabetes mellitus. We don't suspect it. We don't suspect it as soon as we see it. But we keep on looking at cases. That's the time when you will be able to make diagnosis. And that's why I said the link between the skin and diabetes. Thickening skin, just like scleroderma, could occur. Scleroderma-like skin is known to occur. Another thing which could occur is what we call a sclerodema. This is all scleroderma. Another thing is sclerodema. See, I am one of those persons who diagnose this very, very frequently, because this part of the skin will get terribly thickened, terribly hard. It will be board-like. Because I have the bad habit or good habit, I don't know, of patting my patient when he or she leaves my cabin. Don't worry, nalla doing a poito vaanga. And at that point of time, I'm able to diagnose the sclerodema. When you pat on the back, it will be so board-like and hard. Call back the patient, write the investigation. 99% of them will be diabetics. The other thing that we could have is what is known as the diabetic hand syndrome, because there's limited joint mobility. We've all heard about the arthrosis that occurs. We know about the frozen shoulder that occurs. But then there could be limited joint mobility, which you call as LJM, limited joint mobility of the fingers, as well as scleroderma-like skin, SLS we call it. So both put together, the patient develops, I had a picture of it, somehow I missed it, what is known as the prayer sign. When the patient comes in and says, Namaskaram, at that time itself you can make a diagnosis. And these are not given in the books, my dear friends. Now, are there known treatments? Very little treatment is available, and we all believe that controlling the serum sugar is going to help. And when I told you about the different consequences, I also told you about the yellow skin, the skin color rather. A yellow skin can occur. It can change the nails of the skin, color of the nails, sorry, or this type of thing. Now, this is something which is not at all related with any form of dyslipidemia, although we call it a form of xanthoma. It's known as xanthelasma palpebrarum. Any amount of biochemical investigation that we do, you will not see any hypertriglyceridemia or anything of the sort. You must rule out diabetes in these patients. This yellowish deposits that you get on the eyelids, or this type of an orangish face. This lady just came in with an orange face, which again makes us easily suspect diabetes mellitus. Vascular manifestations, so many again. It could be small vessels in the form of it could be large vessels in the form of macroangiopathy, or they could be small vessels in the case of microangiopathy. Physicians don't need to be told about microangiopathy where myocardial infarction can come, but it's the macroangiopathy which you must be knowing about, where there is a lot of threat to the limb. And this macroangiopathy could lead on to different manifestations of a dry skin. Ichthyosis, which we call dry skin, loss of hair in the skin, and also as a result of which there could be so many other neurological changes which I'll be telling now. Microangiopathy, as I told you, the alert is small blood vessel changes affecting not only the heart, but also the retinal and the renal vasculature, leading to blindness and kidney failure. That is one thing which one has to be very, very careful about and watch out for. This type of microangiopathy, which comes like a purpura. This finding is another thing which my colleague and I have published. You look at the nails, and look very close to the posterior nail fold. Are you able to appreciate this red line? You should be able to appreciate it here. very close to the nail fold. Red line here. Can you? Well, if you can you or can you not? Look at this red line. Now this we have described to occur in diabetes, and the link between the skin and diabetes to be very important there. Then of course Sir told us about different forms of pathis, including dermopathy which could manifest as hairless skin over the legs, loss of hair over the legs, loss of hair over the forearms, and blistering disorders of diabetic bulle disease. 3 forms of blisters are known to occur. Spontaneous blistering, which are non-scarring. You could have a second form where it could be hemorrhagic and which can be having scars and can cause thinning of the skin or atrophy of the skin. A third type, which occurs only on the sun-exposed areas, which I showed you earlier in porphyria cutanea tarda. This is the diabetic bulle, which could occur in different forms and can really look like the more dangerous pemphigus. But this is not pemphigus. You treat the diabetes and everything goes down. And you can also boldly treat these patients with systemic steroids. Don't look at this now. Only about you can treat with systemic steroid and give the necessary anti-diabetic. That magic, I learned from Prof. Viswanathan. I live very close to MV Diabetic Center. I'm very close to Dr. A. Ramachandran, Dermatologist, and my classmate is Prof. Viswanathan, again, Dr. V. Mohans, Diabetic Center. I go to all the 3 centers. That's how I collect a lot of these pictures. Now, one time, about 25 years ago when MV was alive, I was going to see a case. They called me. Then he looked at my face. He said, "What's wrong, Jayakar?" I said, "No, sir, I have to start this patient on high-dose steroids." He said, "Start." I said, "I'm worried about his diabetic status." He said, "Don't worry, man. We will look after his diabetic status. We can give him any amount of insulin. There is no limit in the quantity of insulin that is used." He said, "Just don't worry. You give your steroids and go. We'll take care of his sugar levels." That was the time when I really became very, very confident using steroids, even in patients with diabetes. Because there's no upper limit for the dosage of insulin, as long as it is monitored correctly. Here's another condition, necrobiosis lipoidica. I told you again, there is so much of an overlap in the degeneration of the proteinous material that is present in the skin, particularly the collagen. And when we use the term necrobiosis, it simply means complete degeneration with incomplete regeneration. Because quite often even the books of many people do not give the correct meaning of necrobiosis. And that's what happens in diabetes. Necrobiosis along with lipid deposition. Now this can occur even in non-diabetics. When it occurs in diabetics, we call it necrobiosis lipoidica diabeticorum. But just these are only names playing. The dermatologist is well known. I'm sure Dr. Barney is well known for using big terminologies. I'll use one terminology in a short while from now. So this is the necrobiosis lipoidica diabeticorum, which can easily be diagnosed with this type of necrotic area with partial regeneration and also the yellowish discoloration which does occur, and control of diabetes is very, very important. A very closely resembling condition what we call as granuloma annulare. Now we come to neuropathy. Neuropathy, 3 forms, autonomic, sensory, and motor neuropathy are so well linked with each other in diabetes. And when they get linked with each other, that's the time when you start seeing this dry skin. Now this dry skin cannot say that the patient is diabetic, but certainly should tempt the physician to rule out diabetes in these patients. Dry ichthyotic skin, which can start splitting and breaking, fissuring of the skin could take place. And apart from this autonomic neuropathy, you can also get motor neuropathy. And yet another finding which my colleague and I have seen is, in this motor neuropathy, there is always what we call as splaying of the toes, splaying of the toes. The distance between the two toes, the greater toe and the first toe, is very much increased. Very much increased. I'll show you pictures. Look at this space. This space is widened when compared to the other spaces. It's not so in others. It's not so in others. Of course, this type of motor neuropathy leading on to wasting of small muscle hands, well known. But it's in the foot that what is important. Foot that is what is important, with which you could link this spacing to diabetes. There are more linking which I'm going to show you shortly, but it's not going to take very much time. Then you have the sensory neuropathy, eventually starting off as probably just as callosities or calluses, which can break down into huge, large ulcers, what we call as malperforans. This is what I've said. Acquired perforating dermatosis that could occur. Now, usually you find this in patients who are having diabetic nephropathy. And CKDs, you'll find a condition which we tend to call as Kirle's disease. K-Y-R-E-L-E-S. Kirle's disease is hard to remember. If that is hard to remember, you can remember it as hyperkeratosis follicularis et follicularis encutum penetrans. It's easier to remember that way. And I told you, the dermatologists are terrible fellows for such terminology. Call it Kirle's disease and go. But then Barney will be saying, ah, yes, correct. When I was a student, I found it difficult to remember. Hyperkeratosis follicularis et parafollicularis encutum penetrans. It means just thickening of the skin around the hair follicles, extra follicular areas, and penetrating into the skin. That's all. This is what we see in Kirle's disease. There are some syndromes known to be associated. Mostly you don't get to see them quite often. If you're very lucky, you can get to see. My 40 years of experience certainly should give me some amount of luck, if not knowledge. I've seen cases of Lawrence-Seep syndrome where you find this type of large lip, and clitoromegaly is one feature which you find in this. I can't take photos of that, and a lot of dystrophy. Now, a group of disorders known to be associated. From here starts the linkage. From here starts actual linkage that I'm going to keep mentioning about. So many conditions. Psoriasis with lichen planus, skin tags, bullous pemphigoid pruritus, and finger pebbles, which we also are about. I want to impress upon the psoriasis. I want to impress upon them. You are seeing any number of psoriasis. You are seeing any number of diabetics. About 20, 25 years ago, I said in a public forum of dermatologists, I said every third diabetic has got psoriasis and every third psoriatic has got diabetes. There were many people who looked at me cynically at that time, but now they all agree, You go tomorrow and look at your practice. See your records where you've seen psoriasis and see how many of them are diabetic. More than 1/3 of them will be diabetic. Or see your records of diabetes. More than 1/3 of them will have psoriasis. So very common. And what is important here is most of these patients will also be obese, and most of these patients will have gone through some form of surgery, particularly your CABG they would have gone for. This again, as I told you, about 25 or 30 years ago, I saw my psoriatic patient being wheeled in to the ICU. Then they said, sir, you please come and give your opinion for that. That was a national hospital in Chennai. By the time I went, he was dead. They said the cause of death, myocardial infarction. That's the time when I started investigating this patient. And I have with me a good number of patients who are above 90 years, who have survived all forms of complications of psoriasis. I'm having about 19 of them. I'm just trying to make them 25 and then take a group photo with them, have a get together with them, because to live above 90 years is something great in psoriatic patients, because they tend to lose about 7 to 10 years of their life because of diabetes or because of other complications related to diabetes, and I show you how. Just pictures of psoriasis, which all of you have seen, just to show the CABG graft being taken and put there. Vitiligo was yet another complication, like in plainness. Now, complications due to therapy could occur. Different forms can occur, right from hypertrophic scars to atrophic scars. Here are examples where you can get a fixed drug eruption that you could get due to oral hypoglycemic agents. Or when you keep on giving injections, keloidal tendencies could be there. Or atrophy of the skin could take place at points of insulin. Calciphylaxis is yet another link that one should know with diabetes. This type of darkening of the skin where so much of calcium is being deposited, not in the skin, please. Here the deposition is in the blood vessel in calciphylaxis. And most of the time they end up with thromboembolic phenomenon with necrosis, and the cause for this calciphylaxis mostly is because of patients who are on dialysis. Then we have another form of a condition known as nephrogenic systemic fibrosis, and these are again patients who are on this gadolinium toxin exposure. But these are things which we really don't try to link with diabetes. We just treat them separately, but I would like to really bring in this forum the importance of this nephrogenic systemic fibrosis. Severe pain. Patient will be a diabetic, having thickening of both the thighs or thickening on the umbilical area with so much of pain. All you have to do is start giving steroids, and this patient is going to be all right. Now, can we learn from other metabolic syndromes? We know there's so much of metabolic syndromes associated with diabetes. The hypertriglyceridemia, hyperlipidemia, hypercholesterolemia, the waist circumference getting increased. Can we learn? Of course we can. And this is, I told you, I'll show you some of my studies of comorbid conditions associated with psoriasis. My interest in psoriasis is very, very high. I've written 3 textbooks on psoriasis, and I have many of my articles which are published. Particularly my academic colleague is Professor Parimalam Kumar, who is currently the head of the Department of Dermatology at Madras Medical College. We have been able to publish a number of papers in psoriasis and show how they are connected with other conditions, other comorbid conditions. And if you look at them carefully, examine them carefully, you will find that the skin plays a major role. How? How does it play a major role? Here you see what we call as the psoriatic march. Now we know most patients with psoriasis are obese, they smoke, they take alcohol, for reasons best known to them. And this could lead on to systemic inflammation, leading on to insulin resistance, endothelial dysfunction, atherosclerosis, and cardiovascular disease. What started off as psoriasis, mild form of psoriasis, and the patient has not been treated, can lead on to cardiovascular disease. That's why I said you can save 10 to 12 years of the patient's life. And when I find old patients with psoriasis, I collecting them and making data based on them. And to look at it further, psoriasis with systemic inflammation leading on to insulin resistance, which can be proved by OMA-IR, leading on to endothelial dysfunction. Now, apart from this, please do understand there is another cycle where psoriasis is occurring as a result of increased proliferation of the skin but decreased differentiation of the skin. And when this increased proliferation, you can get cutaneous tags, you can get acanthocynuria, that is the dark pigmentation that you get over the neck and over. That's the type of link that I want to really make people appreciate, not just the cutaneous manifestations. And further to that, look at this. The relationship with the ovaries, with the theca cells of the ovary leading on to PCOS. Did we ever think about 20 or 25 years ago that psoriasis could affect the theca cells of the ovary and lead on to polycystic ovary disease? And this polycystic ovary disease leads on to hyperandrogenic states. Doesn't stop there, my dear friends. These hyperandrogenic states could lead to so many other conditions. And psoriasis could lead on, after this, atherosclerosis, adhesion molecules, leukocyte extravasation, coronary artery calcification, and myocardial infarction. So it's all through diabetes. Psoriasis does not directly cause myocardial infarction, does not cause directly. It's all through diabetes and insulin resistance. So the link is very, very important. I'll show you examples. Androgenetic alopecia, in a few nowadays we call it female pattern hair loss, associated with so much of acne and also cutaneous tags in a diabetic female, which one should be able to recognize this fast. This is something different. He is wearing a wig. So that's different totally, but still you have to be careful. When you get this type of male pattern baldness or androgenetic alopecia along with acanthosis nigricans, must rule out diabetes. So even balding becomes important. Those days I remember when I used to read a little bit of it, I didn't have to read much of Harrison, but when you read Harrison's myocardial infarction, the specific phases used to be given. A very high forehead, with balding. We never knew to connect it, but now we know how to connect it. This type of papules which you get on the back of the neck, again associated with diabetes, linked because of hyperproliferation. The diabetes by itself, apart from causing the known diseases that we talk about as skin manifestation of diabetes, I'll show you some more examples which are more interesting. Acanthosis nigricans, told you, associated diabetes mellitus. I'll show you several other examples of acne vulgaris. Here you see acne patient. Now most of these patients, I investigate them thoroughly to make sure I don't miss, and that to acne with this type of hair. You'll find many of these girls, young girls come in and say, I'm also having hair loss, I'm also having dandruff with acne. Please rule out diabetes in them, at least insulin resistance you should definitely rule out. See this pre-adolescent girl with insulin resistance. Look at her insulin readings, 12.4 and 55.9. They're fasting and postprandial. When you're all physicians, I don't have to tell you, when you do a blood sugar level and blood insulin level, and you find that the postprandial blood sugar is less than the fasting blood sugar. We always expect the PB blood sugar to be higher, but when it is less, you suspect insulin resistance. Or when you look at the insulin level, if the postprandial insulin level is more than 4 times the fasting insulin level, again it's insulin resistance. So these are simple, ready reckoner methods by which you could diagnose in patients. See a pre-adolescent girl having this type of change. We don't expect so much of difference, more than 4 times. And this patient has to be treated minimum with glyphosate, metformin. We have to treat. Only then they don't get these syndromes which are known to be associated, what we call as the Saha syndrome. Seborrhea, alopecia, acne, hirsutism. Put together we call it as the Saha syndrome. We have what is known as the Hair-Hand syndrome. This is again described by me and Dr. Parimalam. Hyperandrogenism, insulin resistance with acanthosis nigricans. We were the first to describe this. It's been published. And look at the findings here. Fasting blood sugar 101 and PP is 93. Told you, it's an indication of insulin resistance. Fasting insulin 19, PP insulin is 139. So all are treated with metformin 500 milligrams BID, along with, of course, the isotretinoin that we have to give for these children who have acne vulgaris. So there are examples where there is a lot of link between diabetes and the skin. It's not skin manifestations of diabetes that I want to impress upon you, that you can take any textbook of medicine or any textbook of dermatology which will give you. Now the good question is there androgen excess in men? Is there androgen? We always think men are very hyperandrogenic. There is androgenic excess in men. Look, this chap is having balding, he's having acanthosis nigra and acneiform eruptions all over. So these do occur, and again this we have described as the apparent syndrome. The acne, patterned alopecia with acanthosis nigra. So the learning points, I'm not using the word finally, because finally will make, the word finally will make the audience very happy. He's come to the end of it. So I'm not using the word finally at all. The learning points are, patients with type 2 diabetes more often develop skin infections, whereas those with type 1 more often have autoimmune related conditions. And now we know there's a huge group of conditions which we call as autoinflammatory reactions or autoinflammatory diseases. Insulin signaling supports normal skin proliferation and differentiation. Skin manifested diabetes may also serve as ports of entry for secondary infection, which we have to be careful about. A congenital infection can be an early sign of undiagnosed diabetes, which we just saw. Watch for dermal side effects of insulin injections and oral hypoglycemic drugs, which again we saw a few pictures about. I think a thorough dermatological examination of all patients with diabetes is mandatory. Early detection and management will prevent serious life-threatening complications. So, finally, I give you this lovely dewdrop on rose petal appearance. We always describe varicella to be dewdrops on rose petal appearance, and say thank you to all of you for your attention.
Generalized pruritus in diabetes. If we examine the skin, there is no lesions, sir. Actually, we are not able to with the naked eye. So, but usually they complain of itching, the diabetic patients. What could be the reason, sir? How can you manage?
This type of pruritus that occurs in diabetics, one has to be again very careful, because that could be an early sign that the patient is going in for diabetic nephropathy. So immediately have a good watch over the renal profile and be careful. Another thing, of course, we don't really relate it to diabetes, is a hepatic profile, also the liver profile, but more so on the renal profile.
Very nice presentation. Brilliant slides. I should compliment you on that.
Thank you, sir.
We do see some lichenoid lesions in patients with diabetes on some of the newer anti-diabetic agents. Can you share your experience?
Yeah, my experience with these patients who are on newer anti-diabetes, most of them develop photosensitivity. They take the anti-diabetic drug and expose themselves to sunlight, take their morning walks, which the diabetologists are advising them. They are the people who start developing this lichenoid reactions.
So they are due to photosensitivity?
They are due photosensitive, but that doesn't mean they should stop their walking. Okay. They should use a sunscreen and go, maybe use covered clothing, protect themselves from sunlight.
Dermatological creams available, they are coming in the combination of steroid plus antibiotic. And how to judiciously we can use exclusively steroid or exclusively antibiotic?
I was keeping that topic for your Trichy conference. The judicious use of topical steroids is very, very important, particularly this type of combinations. The antibiotic combination is okay, sir. But sometimes you'll find these 4 terms, 5 terms and all that. Antibiotic, antifungal agents along with steroids, which is very, very dangerous and should be condemned. I wish we had enough laws in the country which this could become condemned. Antibiotic to some extent we can accept, particularly in patients with atopic dermatitis where there is a lot of staph infection on the skin or even staph colonization of the skin. An antibiotic with a steroid can be to a small extent accepted, but not otherwise.
We have been seeing patients with psoriasis, particularly extensive psoriasis, who find benefit with a steroid cream. Then they go and get it from the pharmacy over the counter and then start using it and become Cushingoid and diabetic. They start off with only psoriasis. But as a result of use of very large amounts of topical steroid, they become Cushingoid.
Not that common, so it's not at all uncommon. But using large amounts of topical steroid is not practical also. I find some doctors prescribing that, which is not at all practical. So how much steroids can a person apply? See, we generally do not allow them to use more than 15 grams for a week, 30 grams for 2 weeks of the highest steroid, clopidogrel or propionate. But here they do.
The problem is availability of over-the-counter
Exactly.
steroid medication.
Exactly.
That is the
government
problem, I
could
think.
really put a stop to that, But then it's impossible. It's impossible. The cities itself you can't do. You just go and say, I want better weight cream. They buy all these steroid creams like Amultajan, Vicks Vapor, and keep it with them in the monthly grocery. It's very, very sad. If they are not available, then this is not going to happen. It's only in India this happens, right?
Yes, sir.
It doesn't happen in the rest of the world. At least the Western world, it doesn't happen. They can't get a paracetamol tablet.
We still use Whitfield ointment.
Whitfield ointment, yes.
Still use.
Good old Whitfield is still very good. Economical.
Near the doubt. So, sir, can you tell the list of conditions, dermatological conditions, absolute contraindication of the steroid? Like, because instead of treating it will worsen, like already you shared on pictures.
All infections, whether bacterial, fungal, viral, whatever. The definite, absolute contraindications for steroid, both topical as well as oral.
Actually, a question from Zoom. I think Dr. A.B. Manivannan. Very elaborate talk, Dr. Jayakar. May I ask you a question? Are these skin lesions you showed on the screen related to diabetes patients only, or do they occur in non-diabetic patients also?
Dr. A.B. Manivannan from Malaysia. All the pictures that I put are related to diabetes, but they can also occur in non-diabetics. For instance, fungal infections can occur even in non-diabetics. Folliculitis, furuncles, carbuncles can also occur in non-diabetics. But what I put is what I saw diabetes in. A.B. Manivannan is yet another classmate of ours. Sukumar, Kodandapani and all of us. And he's closely related to Vellore because his in-laws place are here. Hello to A.B. Manivannan.
So, no more doubts? Okay, sir. So now we came to the climax of the meeting. Yes, it's vote of thanks on behalf of Office API Vellore branch office bearers and executive members, and our chairperson Professor Dr. Sheshatri sir, and past chairman Dr. Barney ma'am, Dr. Sukumar sir and Sambat sir. I extend my gratitude to the renowned speaker Professor Dr. Jayakar Thomas sir, who humbly accepted our invitation in spite of his busy schedule and delivered an excellent lecture. So with the interesting slides and rare dermatological manifestation pictures, and I am very new to learn about the knuckle pebbles and all these new terms. So thank you so much, sir. Quite interesting. And also I thank each and every one of the physician who actively participated in this fine evening, and also the postgraduate who travel here. And also I extend my gratitude and thanks to our state APA chairman, Dr. Sethuraman sir, who traveled along and gave a lecture about the importance of the APA and social activities, and actively involve the postgraduate and improve the academic activities, sir. And also I'll try to implement your advice, sir, to conduct the APA meeting in our medical colleges and actively involve our postgraduate. Thank you so much, sir. And I thank each and everyone, and also I thank the audio recording, the Saranya studio team, and also I thank the former friends Subramani and Jagadish for organizing this excellent forum. And I thank each and everyone. And also I request everyone to join the dinner. Thank you so much.